Well, I want to welcome everyone this morning to our monthly ABIN webinar. We are so excited that you're here with us this morning. We know it's bright and early, but we have a fantastic speaker today. I want to remind everyone that by staying on today's call, you are giving us your permission to be recorded, and this recording will be posted to the ABIN website along with the slides. So please know if you're wanting to reference this, it will be on our webinar. All right. Just so you know, next month we will be having ACI and they will be talking about the behavioral health dashboard, and we'll have Dr. Joe Thompson, and he will be talking about social media use with youth. But today we have Dr. Daniel Sumrok. He is the medical director at Landmark Recovery, and they operate multiple treatment centers, which operates multiple treatment centers, including Landmark Recovery in Morrilton, Arkansas. With over 40 years of experience, Dr. Sumrok has extensively worked in addiction medicine across Ohio, West Virginia, Indiana, Tennessee, Washington, D.C., and the East Coast. A former U.S. Navy hospital corpsman during the Vietnam War, Dr. Sumrok has dedicated his career to understanding addiction and advocating for trauma-informed treatment approaches. As a board-certified addiction specialist, he has played a key role in reshaping how we view and treat substance use disorders. With that, we want to give a warm welcome to Dr. Sumrok, and we'll turn it over to you.
Thanks a bunch. I guess, Kyle, if you can get us started with slides. I want to describe sort of how I got here. I will tell you that in 1976, I was discharged from the Navy the first time. Can you all hear me? Yeah. Somebody
Yes.
say yes.
Yes, we can.
Good.
We
Okay.
can, but I'm going to ask, if you're not speaking, would you please put yourself on mute so we can all hear Dr. Sumrok?
Yeah. So 1976, I was discharged from the military, and I was a Navy hospital corpsman. And at that time, I was discharged. I was working as the chief corpsman in the emergency room at San Diego Naval Regional Medical Center, Balboa Hospital, right across from the zoo. A great big hospital. I think it was 1,800 beds at that time. It was an emergency room where we saw about 500 patients a day. And my experience then was with a different kind of trauma. It was with surgical trauma and combat injuries and plane crashes and car wrecks and that sort of thing. I also had the great good fortune then to be required as part of my job to round with the young physicians every day. And every day we went to the surgical ICU and the medical ICU, and we looked in on the patients that had come in through the emergency department. And the great good fortune was that there was a fella there who led the rounds, was the attending physician, and Joe asked every day and made the point every day, what do you think is the underlying cause of this patient's condition? And Joe Alpert was his name. Joe wrote a big thick book called The Heart, and you all may be familiar. He was the chairman of internal medicine later at the University of Arizona. But his point was that if you're a real physician, you're looking for the causes and not just treating the symptoms of a condition. And if you have a patient with an ankle edema, that was an example he would use a lot, and you simply start writing for furosemide, but you don't know what's happening with the patient's kidneys or thyroid or heart. You're really just treating a symptom. And his point was, look for that underlying cause. And so I sort of incorporated that into my own brain and began to think of physicians as people that weren't just treating symptoms. Certainly symptoms are important, but also looking for the underlying cause of a disorder. Um, and again, discharged in 1976, I want to tell you that, full disclosure, my life felt a little fragmented. I found myself drinking. I never had a drinking problem, but all of a sudden I was drinking. I found myself divorced because I was drinking and was a pretty crappy partner. I found myself a single parent of a 1-year-old entering the first year of medical school. I was trying to live on the GI Bill, which was about 300 bucks a month, and barely paid for the whiskey. Everybody that loved me hated me. It was again my life. Just I had a chest full of medals and pretty good grades, but my personal life was a mess. And uh, and so again, great good fortune. The way God works is that that spring of the first year of medical school, someone came from the VA. I was at Marshall University in West Virginia. I'm a hillbilly, and the guy from the VA said, if anyone in this class will come to the VA and do some kind of research for us, and that was it, some kind of research, didn't specify anything, we'll pay you $750 a month. And truthfully, I didn't have a passion for research or a topic that I was interested in. I was trying to keep my head above water. But $750 a month sounded like winning the lottery, so I thought I'd go ahead and do it. And I went down to the Reagan was president then. They had these things that they called storefront vet centers, and those storefront vet centers were an attempt to decentralize care for veterans and make it more widely available. And I went down to the storefront vet center, and again, as the way God works, I went in there, and as my eyes adjusted to the light, I realized I knew every guy in there because they were friends of mine from school. They were friends that I was playing ball with. They were friends that I was drinking with. They were friends that I was playing music with. They were all also veterans, so we had this immediate connection. And then there was a PhD director there, a guy named Steve Giles, and a woman psychiatrist named Mildred Mitchell Bateman. And Mildred, I didn't realize, but Mildred was really kind of a foundational figure in psychiatry, one of America's first Black women psychiatrists. And Steve Giles, a PhD type, was a psychologist who had studied at the University of Colorado, and his interest, special interest, was in biofeedback. So for the first couple of months, I was just happy to be any place that they were paying me 750 bucks a month, and I didn't do much work. But I did learn about biofeedback, and I realized that pretty quickly that biofeedback can be it can be mastered. A patient, or certainly me as a first year medical student, I was able to figure out how to lower my heart rate and raise my skin temperature and change my galvanic skin response and all those things that you can do with biofeedback in about 5 minutes. And it reinforced the notion that your your mood, your adrenal outflow can be controlled by learning about mindfulness, relaxation, and it wasn't a difficult task. But again, 2 months into it, I hadn't done really much work, and so one day I pulled out a pen. Can you all see this? I can probably remember those things, pens, and a piece of typing paper, and I sat in group, and I guess there was about 10 of us in the circle, and I thought to myself, you know what I'll do? I'll write a paper and see if I can describe this new thing. It was 1980. The DSM-3 had just described this new thing that was called post-traumatic stress disorder. None of us really knew what that meant, what it looked like, except all my friends who had been going to the VA started to acquire this label, PTSD. And so I thought, well, I'll just see if I can describe it so that people will, coming after me, other medical officers will be able to recognize a case when they see it. And so I looked at the first guy, and I took my typing paper and my pen, and I thought, what do we have in common? And I wrote down divorce. And I looked at the next guy, and I wrote down problems with the law. And I looked at the next guy, and I wrote down substance use. And I looked at the next guy, and I wrote down difficulty concentrating. I looked at the next guy, and I wrote down trouble sleeping. And the next guy, and I wrote down depression and thoughts of suicide. And I wrote that up, and I called it, the something like the public health legacy of Vietnam and Appalachian combat vets. And it was published in the West Virginia Medical Journal. And so, for a first year medical student, it was like, a tiny feather in my cap. And I got some attaboys at the medical school. But as I was telling Jenny early on, that mostly nobody noticed it, right? If you want to make sure that nobody ever sees something that you write, publish in a medical journal, because almost nobody reads that stuff. And I told Jenny, my mother liked the article, but she fell asleep halfway through. But it turns out that it was one of the first times that people were making the observation that folks who had had trauma had this nexus with those other symptoms. And that to me said, hey, sleep troubles and difficulty concentrating and thoughts of suicide and depression, those are, and substance, those are difficulty with relationships, those are really symptoms of post-traumatic stress disorder. And so that's just the way I began to think about trauma. I'll tell you, fast forward, you can see all that stuff on there. Go ahead and change to the next slide, Cal. Yeah, yeah. So fast forward, I can't, I went back into the military. They paid for my medical school and my residency training as a first as an OBGYN doc and then later as a family doc. And again, I went back to my alma mater at Marshall University, and it's a place that's dedicated to turning out rural docs, right? For rural primary care docs was their mission, and the VA funded that. And so I used the military scholarship to be able to get all my education. When I finally was discharged, I think I spent 22 or 23 years on active duty, and I came to Tennessee. And when I came to Tennessee, I felt right at home. East Tennessee feels a lot like West Virginia, and except it's a little bit more prosperous, and but it's definitely Appalachian culture. And my wife was from a little place called Yellville, Arkansas. Probably some of y'all know where Yellville is. And so I came out here and I interviewed with a doc in West Tennessee, and I came to a county that didn't have a single doctor that was residency trained or board certified in any specialty. And and the guy that I was interviewing with wanted to start a women's healthcare program, be able to do delivery and deliveries and prenatal care. And in this county, by the way, the infant mortality rate in 1990 was about 20 per thousand, which is, if you're familiar with infant mortality, that's about 3 times higher than the rest of America. So long story short, we brought this sort of low tech thing here and called prenatal care, and started a labor and delivery, and we started training labor and delivery nurses. And then I started a PA program, and I began to associate with the folks at the UT down at Memphis at the Health Sciences Center, got in the faculty at family medicine, and uh, and ran into some real scientists. Right, not me. I was a clinician, but I ran into some real scientists, and Dr. Darafinko, you can see, is the first listed author there.
By sections, partial hospitalization, adult rehab.
Yeah. So you can see Dr. Darafinko there. She's in the Department of Preventive Medicine. I think she's actually the chair now. And these other collaborators were from both the University of Tennessee and the University of Memphis. And and so I thinking about what's the root causes of substance use disorder and my experience with trauma, I began to collect data on the patients that I was treating. In September 2019, this is the cover of the picture shows here of the Journal of Addictive Behaviors, and we published our results. So go ahead on, Cal, to the next thing. Yeah, so this is a little bit descriptive. 75% male, 100% Caucasian. That's a limitation in the study, but like the ACE study, the original ACE study was mainly Caucasians. It was folks who had Kaiser Permanente insurance in San Diego. They pretty good jobs. I think the average age was 38 in that study. You can see that ours was 39.9, so pretty close. They had 17,000 people that finally reported in the ACEs study after doing 25,000 questionnaires. Which, by the way, if you do a study using a questionnaire and you get 17,000 responses, almost 18,000 responses out of 25,000 questionnaires, you're really doing well. If you get 10% of people to respond to a questionnaire or a survey, you're getting some high numbers. So Dr. Folletti felt, and I felt that reflected that people really wanted it known what had happened to them. And we'll talk more about Dr. Folletti in a minute. The number of office visits was 1 to 80. I think there were around 2,000 total encounters. You can go to the next slide, please. Yeah, 2,052 encounters. Here's the really interesting thing about this. The median number of visits to the time of relapse was 1. That means that most people relapsed the first day, right? They came to see me, and and I, wrote a buprenorphine prescription. They got registered. They got, we got to know each other a little bit. I typically screen people. I use the ACEs questionnaire, and but a third of the relapses, more than a third, occurred on the first day. And one of the neat things that we found is that our care showed that the more people stayed in care, the better they got. The less likely was there a chance of relapse. When it says relapse, we don't even use that word anymore. But relapse, we called it a relapse if the urine drug screen showed an inconsistent result, or if the patient self-reported. Or if we saw on our physician monitoring data bank, prescription monitoring data bank, that the patient was receiving a controlled substance from another prescriber that wasn't reported. Uh, Hal, can you move on to the next slide, please? Yeah, so there's this general estimating equation. This was simply used to be able to look at data that came from patients that have varying number of visits, and allow us to remain statistically consistent with what we were doing. But here's the interesting thing. What we found is that for every single unit, the ACEs, there are 10 questions. And if you had a score of 1, you had a 17% odds of relapsing higher. If you had 2, it was 34%. And it was a very linear, right? A dose response, a very statistically linear kind of a relationship. It looked like the more trauma you had, the more likely you were to relapse. And you go on to the next one. Yeah. But here was the neat thing too. It looks like your odds of relapse were lowered by about 2% for every visit. So that every single time somebody came to see me and got this, what I call trauma-informed delivery of care, there was a reduction in their likelihood of relapsing by about 2%. Now, if we just think about that for a second, if the odds were higher for every increment on the ACE, it would take 8 or 9 visits to erase that, or to mitigate that 17% increase, right? Does that make sense? Y'all follow? You agree with that? I hope everybody also is familiar with what I'm talking about, the ACEs, and when I talk about things like adrenergia or adrenal outflow, and I hope we all are agreeing, that trauma is actually an etiology of substance use disorder. I can tell you that I've gotten a lot of pushback from this, from other scientists, from real scientists again, and I've gotten a lot of pushback from clinicians. Treating trauma can feel messy if you're and I don't know what other word to use, but it's not as simple as putting stitches in and closing a laceration. It's not as simple as writing a prescription for amoxicillin. It really takes engaging with the patient in a way that's collaborative and doesn't feel threatening. And most docs really prefer walking as fast as they can, generating prescriptions. Of course, in those days we generated them with one of these things. Now we generate them differently. But you can see it looked like the longer you stayed in treatment. Go ahead to the next slide, please. Yeah, so this is shows the results of staying in treatment. After about 60 days, or 60 visits, we didn't really have anybody in our group that relapsed. And this group went on for 15 years. So I also add something here that it's not included in the presentation, but uh, and this is almost hard to believe, but we had 100% employment through most of this entire existence of this group. And what happened there was that several of the patients were, they were physicians, they were attorneys, they were guys that knocked down trees in the woods, they were folks that did blue collar type work. But when someone came in, one of the first things in group that we would ask each week is there someone in here that needs a job that doesn't have one? And when someone would raise their hand and say, I need a job, usually someone else in the group would say, well, come on over to, my factory, or come on over to my company, because we're hiring, and we'll fill out an application for you this afternoon. So uh, again, I think that was a real benefit of people staying in treatment and establishing those sort of secure kind of empathic relationships that look like they're so important to all of us. Uh, the more you stay in treatment, the less likely. And what do they say in AA, right? At the end of every AA meeting, they say, keep on coming. It works if you work it, right? And I have to say that, and I know probably this is the wrong group to remind us. I'm preaching
All
to the
right,
choir to
baby.
you, but this is a chronic illness, right? This isn't like having the flu or a broken leg or something that's an acute illness where you get treated and you skip home whistling and you get to forget about it. You're healed at some point. This is a trauma, and the effects on your brain stick with you forever and ever. Uh, I want to mention a couple of foundational things that shaped my thinking, and I know that you all are aware of some of these things. John Bowlby's attachment theory. If you're one of those lucky people that had a secure attachment with your mother, uh, good for you. But a lot of us didn't have that secure attachment, and that the most important relationship you'll ever have in your life is the one that you have with your mother, and it becomes the template for the way we shape our relationships going forward and what feels right to us. I want to say that the attachment theory and writing about that really shaped my thinking a lot. I want to say that I had no concept whatsoever about the childhood trauma thing. And I was thinking about combat and how that affected people. I wasn't thinking about what Vincent was thinking about, Dr. Folletti in '95 in San Diego. He was thinking about verbal abuse, physical abuse, sexual abuse, emotional neglect, physical neglect, incarceration of someone in your home, active drug use by someone in your home, domestic violence, divorce. And I would say that exposure to those kind of things, exposure of young brains to those kind of experiences, whether it's combat or whether that's childhood trauma, it changes the way your brain works. And, one of my favorite people is Dr. Steve Lloyd. He's kind of a famous dude who's the central character in the book Dope Sick, and he's a dear friend of mine. And he says this all the time, and of course you've all heard it. Neurons that fire together wire together. I'll tell you another anecdote about a patient that lives here in my town. She's a sociology professor, and she's a PhD type, and she came to me 20 years ago, and she said, Dr. Sumrok, my father sexually abused me from the time I was an infant. In other words, pre-verbal, until I was about 10 years old, and I realized that something was wrong. And she said, about that time, I think she said it was 11, a friend came over and said, hey, let's smoke this joint. And she said she smoked a joint with her little friend. And she said it was the first time in my life I ever recalled feeling relaxed. I'll tell you that, that's a pretty strong signal to your brain that whatever you just did, in her case, smoking weed, uh, we need some more of that in here, right? That was good for us. That was adaptive. That gave us relief. And remember, all substance use disorders look like they're driven in large part by dopamine, right? The pursuit of relief or reward. And Jenny and I were talking about this before we began. If you were, out here in West Tennessee yesterday and it was rainy and the, lightning was crashing and it was cold and windy and, your brain would say, Jenny, get in the house, right? Put a coat on, get warm. If you were hungry, your brain would say, eat something. If you're tired, it would say, lay down. And normal brains are supposed to take us to comfort and safety. And so, when we think about uh, that, and we realize that when someone finds a substance that works for them, it doesn't take very long before that becomes a kind of a go-to pursuit, if you will. That becomes, remember that the definition of addiction is the compulsive pursuit of a substance or a process despite a known negative consequence. So after someone learns that there's relief or reward in that substance, and it doesn't take long. Remember Ivan's dog? It didn't take him long either, right? It's I think 3 or 4 times, and all he had to do was ring the bell, and Bowser would begin to salivate. I don't remember what Ivan's dog's name was. I don't think I ever knew actually. But humans are the same way, and then there's not much thinking that occurs. And there's a generalized response to any sort of anxiety. And anxiety then is always interpreted as a craving. Somebody calls and says, "Hey, Sumrok, you dress your kids funny." My brain would say, in those days would say, "I need a drink," right? And or I need to relax in some way, and I know this technique that helps me relax, and it works until it doesn't, right? And it works until your liver starts to turn into a brick, or you lose your job, or your wife divorces you, or any of those consequences that occur as a result of substance use disorders. And we see those across the spectrum from IV drug use to alcohol. By the way, in our experience at Landmark, and also my experience at the University of Tennessee, about 60%, about two-thirds of our patients are for alcohol use disorder. So even though opiates have gotten all the attention and the opioid crisis and all that, and the drug use deaths and fentanyl is all over the headlines for killing 100,000 people, and certainly those are every one of them a tragedy. Alcohol's been killing more people than that for 40 years, and often goes sort of unrecognized in terms of the impact. So, yeah. So here's a couple of conclusions, right? Trauma-informed care may be quite relevant. Dr. Derifinko wrote for rural individuals. I'm going to tell you that I don't think rural makes much difference in terms of that. I certainly, there are certainly differences in public health risks, and rural America has got some major challenges, especially in the areas of behavioral health and substance use care right now. And rural health has sort of fallen off a cliff in the past 20 years, whereas urban health is getting a little bit better. But I think when we're talking about neurobehaviors and adrenergia, it doesn't matter if we're talking about someone that lives, in a rural zip code or someone that lives in town. Now, what does make a difference is the resources that are available, are the resources, and we see. For example, in Tennessee, if you look at the county where I am right now in Carroll County, you'll see that the life expectancy here is about 20 years less than people that live in Williamson County, which is Franklin, Brentwood, sort of the hoity-toity area south of Nashville, where the country music folks and the insurance execs all live, and it's quite a wealthy place, and there's lots of resources, and so it really does make a difference about the resources that are available, but it doesn't make so much difference about how the brain is working or how the biology of trauma. Staying in treatment obviously reduced relapse risk, and so that gives us a place to focus, right? When over at Knoxville at the UT, I did another study that's not included here, and it was an internal study done at Bradford Health, where we treated again the pilots and the physicians and the lawyers and the nurses and a significant population of Medicaid folks too. What we found out is that you could predict who is going to leave treatment against staff advice by looking at their ACE score. Just like in this study, we could predict who was going to be successful or who was likely to relapse, or their odds of relapse were increased based on their ACE score. So Kyle, are there any more slides? Go on. I'm not sure. Yeah. So here's questions from the original ACE study, and I mentioned those things, right? Did they swear at you, insult you, put you down, humiliate you, or act in a way made you afraid you might be physically hurt? Again, that's called verbal abuse. Did a parent or adult push you, grab you, slap, throw something at you, hit you so hard you had marks or were injured? That's physical abuse. Touch or fondle you, have you touched their body in a sexual way or try to actually have oral, anal, or vaginal sex with you? Obviously, sexual abuse. Number 4 is about emotional neglect. Did you often feel no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? I'm going to tell you that I have 6 kids of my own, and I've adopted 9 kids through the years. 15 kids. Yeah, that's right. Yeah, that's why just look so old. I'm actually only 40 years old. The truth is that if I don't make every one of my 15 kids feel like they're important or special, I've missed the most important thing I can do for my child, period. And they are important or special. And so are your patients, every one of them. They're somebody's child. Did you often feel you didn't have enough to eat, had to wear dirty clothes, no one to protect you, your parents were too drunk or too high to take care of you or take you to the doctor if you needed it? I think of the kid in my county who's in the back seat of the car and his mom's out trying to score some meth, and he's a 3rd grader, and And that night he's probably going to hear some things, see some things. They probably, would be better off not hearing or seeing. The next day he's going to show up to school in the same clothes. He doesn't have lunch money. He's sleepy. His homework isn't done. When he falls asleep in class, his teacher hollers at him, and now he's had a trauma again. So, I mean, it's really that simple. Kyle, go ahead to the next slide, please. Yeah, I think these are a little bit out of order, but we'll be flexible. Uh, I want to just talk about the bottom highlighted area. The findings highlight the importance of examining the ACE. And I would say just the trauma, we overuse that word trauma, but examining the traumatic histories of patients and individual ACEs on adult health outcomes. Remember that the ACE study had nothing to do with addiction. What Vincent was doing is he had a group of folks that were trying to lose weight, and they were coming to his clinic, and it looked like they were doing pretty well. They were attending a group, and they were adhering to their nutrition plans, and they were on a great trajectory to lose down to their target weights. But he saw that almost inevitably, when people got close to that target weight, they would drop out of group, and he was scratching his head. And Navajos used to say, what's the matter, right? They say, "Tharsint, ah." And so Vincent was scratching his head, and he was thinking, "Tharsint, ah, what's going on here?" And so Vincent decided, he and I are pals now, and he decided to call five of these folks that had dropped out of treatment and to interview them on a Saturday morning. And the first woman came in, and he was doing the interview, and he said, I was kind of distracted. I was looking out the window. Usually played golf in San Diego in the sun, right? Anybody that's been to San Diego, well, they always remember the nice weather. Vincent played golf every Saturday morning. So he said, I was looking out the window and thinking about the links. And he said, I combined two questions that all doctors ask every normal woman, right? And you know what those are. I mean, you've all been doing this a long time. So, when was your last period, and are you sexually active? And he said, I combined those two questions, and I asked that first woman, when did you become sexually active? And she said to me, age 5 with my father. And then, I don't know what you call that, the holy shit bubble went off. And then he said, and then the patient said, without any further prompting, by the way, the reason I left treatment was that if I left when I was still a little overweight, I felt that I would be a little bit protected, a little camouflaged, a little bit less likely to be sexually traumatized again. And then 4 more folks came in right after that patient and told almost an identical story. And Vincent once again said, what's going on here? This can't be a coincidence. Let's explore this further. Over the next couple of years, they interviewed a couple thousand patients, and they collected information on about, I think it was 24 or 25 discrete kinds of traumas that people reported. And then they crystallize that, and they came up with the ACE questionnaire that you just saw the first 5 questions. There are 10 of those questions. Uh, and when they looked at that data, Kyle, go ahead and go into the next slide, please. Here's the second 5, and I said they were a little bit out of order. Go back again, please. Yeah. Were your parents separated or divorced? So what percentage of Americans marriages end in divorce? I think it's over 50% now. I think last I looked, it was 53%, something like that. I'm sure it hasn't changed a bunch. Was your mother or stepmother pushed, kicked, bitten, hit with a fist, repeatedly hit, threatened with a knife or gun? Again, domestic violence. Did you live with someone who was a problem drinker, alcoholic, or used street drugs? Was a household member depressed, mentally ill, or attempt suicide? Did a household member go to prison? Those are the 10 questions. Go to the next slide, please. I can't remember what it is. Yeah. Here's some other things that I mentioned: that racism, historical trauma. If you're an Appalachian kid, you have a historical trauma. If you're a Black kid, you have historical trauma and racism. If you're a kid growing up on the Navajo reservation, you have historical trauma. Poverty by itself is trauma. That little kid who's wearing the buddies and everybody else is wearing Nikes. He definitely feels that he's different. And if you're a fifth grader, a sixth grader, or a seventh grader, sort of one of the most important things is fitting in and feeling like you're part of a group. And if you're the poor kid, oftentimes you don't feel that. You feel marginalized. combat exposure, or like I said, Ukrainian kids today that are sleeping in tunnels tonight, or Palestinian kids hearing bombs go off all night, or kids that live in Memphis. It wasn't an unusual experience for me to be doing an intake at La Paloma in Memphis and hear gunfire outside. Kids growing up in that kind of environment day after day after day, their brains are changing. Serious illnesses, right? If your little brother was, or you, or a patient at St. Jude's and you had a cancer or a chronic illness like diabetes or juvenile rheumatoid arthritis, again, it changes the way your brain works and you begin to react to the protective out of your amygdala to protect yourself. I always think, I don't know how you all think about this, but I think of the amygdala is sort of the emotional fuse box. All the things that have to do with our feelings, joy, sadness, sorrow, fear. Those things are they either terminate those neurons at the amygdala or they pass through the amygdala. So I always say that once we have this trauma, our behaviors become amygdala driven. Protection, hypervigilance, right? That's how I understand that. And it's true that those signals from the frontal cortex take longer to affect behaviors for us to execute those things, that executive function, than things like reacting to a baseball flying at your head, or a car approaching you too fast, or a deer jumping in front of your car. Right? And when those things happen, that amygdala signals danger, and your adrenal gland says, "Hey, let's get some epinephrine, some adrenaline out there." What happens then? Your heart rate goes up, your blood pressure goes up, your little cortisol leaks out of the glomerulosa layer of your adrenal cortex, and your immunity is suppressed. Right, your blood sugar is high. If that happens day after day after day for you, it has health consequences. Next slide, please. Yeah, next slide, please. Yeah, I just put this slide in here for one reason. Go back. Yeah, just one reason. Look at 2019, right at the 20, right in 20 there. That's when COVID hit, right? And what we saw is that rates of this is adjusted rates of drug overdose deaths. We saw that those rates went up by about 30%. Now, I also know a guy, yeah, I know a guy, right? This fellow invented a test called the PEth test. And the PEth test is a way that you can quantify how much alcohol someone's been using for the past few weeks, 2, 3, 4 weeks, maybe. And the FAA required us to run that test on all the pilots that we were treating. And the inventor of that test is, again, someone that I know, and he said, what we noticed is that the number went up by about 30% in pilots during COVID. So did the drug deaths, about 30%. And I don't think that that's a coincidence. I think that that reflects uh, a nationwide, or, in a pandemic, worldwide adrenergia, if you will, collective trauma, if you will. I don't know about you all, but I remember going out the door here, and my daughter Abby then was graduating next week from high school. Yay. With a 4.0. Yay. But I was leaving the house and they were on Zoom school, and it was COVID time, and she was sort of laid out on the couch, and she had a Coke can balanced on her forehead, and I thought, I need to get these kids out of the house. And at that time, I was preparing an address for the NAR, the National Alliance for Recovery Residences. And so I took my two daughters and I had them help me with this presentation, and they didn't realize it, but NAR let me pick the topic, and so I talked about mindfulness, compassion, and mindfulness and compassion in a chaotic world, and spirituality. So my daughters, they had to look up, what does it mean, spirituality, and then they had to find an illustration to demonstrate that thing. And pretty quickly they put together a PowerPoint that was pretty wonderful, really, and taught them and taught me and helped us bond in a way. And then I presented that to the brainiacs at NAR, and they didn't realize that a 12 and a 14-year-old daughter had done that whole thing, and it was really well received. Um, I want to mention a study. Go on to the next slide, Kyle. I'm probably droning onto it. Yeah. Yeah, most of this is true. We found we could predict relapse, treatment relapse. We could predict treatment successes. Uh, and uh, and I think you'll be shocked when you start doing this. Now, let's think about Vincent's study for a second. Go to the next slide. I think I have some of this in here. Yeah, this was in Tennessee. This was 17, I think. This was the relationship between, illustrates the relationship between depression, smoking, asthma, COPD, obesity, cardiovascular disease, diabetes, and hypertension, and trauma. Next slide, please. I put these slides in here to show the shapes of the curves. Can you see that? I mean, the X and the Y axis stuff, and you can see that almost the curves are almost identical. And what it says is that the higher your ACE score, the more likely you are on the top left to be a smoker as an adult. By the way, folks who use opiates, it looks like the co-occurrence between tobacco use disorder and opiate use disorder is upwards of 90%. It's somewhere between 90 and 95, depending on the studies that you're looking at. So it almost guarantees that if you're treating someone that has an opiate use disorder, there's a second diagnosis there called tobacco use disorder, and it would behoove you to ask about that. Uh, um, Look at the slide on the top right. Again, same curve. 0, 1, 2, 3, and 4 ACEs. You can see how how your chances of becoming an alcoholic are increased. A perpetrator of domestic violence, men and women. You can see in the bottom left. Again, same shape of the curve. And then look at the thing that we call depression over there. That looks like it's, when there's a dose response linear kind of a relationship like this, it suggests causality. Now, again, when I say causal, right, scientists hate that because they all remind me, well, trauma doesn't cause substance use disorder, but there's this dose response linear relationship that exists, this link that exists between the amount of trauma a person is exposed to and these kind of adult outcomes. And by the way, Vince's original study show, again, they weren't looking at these things initially. They found out that the higher your ACE score, the more likely you were to have heart disease. Right, the number one cause of early mortality in the United States. The more trauma, the more likely you were to have heart disease. Now, maybe that dotted line is cigarettes. Maybe it has something to do with alcohol. I mean, we know it does. The second thing that they found out is the more of trauma you had, you more likely you were to have a cancer. The second leading cause of early mortality in the United States. The more likely they were to have COPD, right? Again, the dotted line, you can see it right in front of you. The more likely you were to have an accidental death. So that's drownings, car wrecks, overdoses, falls. Uh, those things are related to, in a linear dose response way, your childhood exposures to trauma. Go ahead to the next slide, please. Also, that was true with depression and suicide. That was true with hypertension and stroke. So now we're talking about, I think I just named 7 of the top 10 causes of early mortality in the United States. So that's the importance of understanding what trauma does to our brains, what this adrenergia, I'm going to say it, causes. Um, Again, tobacco, this is Tennessee. You can see that, again, same shaped curve. Next, please. Yeah, so this is an interesting one. So this is your likelihood of being an injection drug user. Listen, and by the way, if you want to see all this stuff, you can just Google ACE study and go to the images, ACE study histograms, go to the images. You'll be shocked. If you're not already familiar with this stuff, you will be shocked. This is the most important study that we sort of don't know anything about. Uh, Next slide, please. Yeah, and so again, this was Tennessee. The number says $5 billion annual economic impact. I promise you it was twice that. Next. Yeah, so what do we do about it? And how does this help us? How much time do I have left? Uh, I'm droning on and on. So I will tell you that in our group that where folks seemed like they were doing pretty well, I was describing a patient to Jenny. The patient had come to me a couple of years before this conversation occurred with her in group. And at that time, President Trump had been elected for the first time, and I got an invitation. President Obama had become aware of our work, and and our center was chosen as America's first center of excellence for teaching doctors how to take care of substance use disorder. And when President Trump got elected, he appointed a guy named Tom Price, a physician, an orthopedist, which well, I won't say much about orthopedists, but it should be a psychiatric diagnosis. But anyway, Dr. Price invited me to come to HHS to have a private audience with him, and also with Alpha Stewart, who is a dear friend of mine from Memphis, and she was at that time the president of the American Psychiatric Association, and so he sent me a list of questions that he wanted to talk about a month before. There were 10 things and 10 sort of bullet points. And the first question was absolutely the right question. He, to his credit, it crystallized all of the rest of my thinking just to answer that first question. And it was the same question that the dean asked me at the medical school when I started the department. He said, "What role in your clinical decision making does trauma informed play?" In other words, do I order different tests? Do I ask different questions? Do I prescribe different therapies? How does it affect the care a patient receives? What role in your clinical decision making does trauma informed play? So I wanted to have a real answer, and I didn't want to be arrogant about it. And so I went to the experts, and I took that question to the 275 people that were in group therapy with me at that time. And every day for a month, for hours, we talked about what role they felt trauma-informed play in my care of them. And the best answer came from Miss Leanne. Miss Leanne was from Union City, Tennessee, and she was all of 4'9" or 10, and probably weighed 90 pounds. And when I met her, she came in withdrawal. In those days, we would instruct patients to come in withdrawal, and she was in bad opiates withdrawal when she came in, and pretty miserable, and looked like a wet mouse, and real country. And she was living in her car, and her husband had divorced her, and her kids had disowned her, and she'd stolen everything at the house that wasn't nailed down. She'd lost her job. She sounded a lot like I did about 40 years ago. And but she came into the group, and by the time we were having this conversation about trauma informed, she had stabilized. She was on MAT. She had rekindled her relationship with her husband. She'd gotten her job back. Her kids were letting her watch the grandkids again. They were, her life was really on track. And by the way, she became our sort of Walmart greeter for the group. She was the person that would, when someone would come in and they were miserable and their first visit and they were scared and they didn't think treatment was going to help, Leanne became the person that would say to them, "I remember when I failed as bad as you do. Come on in. I'm glad you're here. Just keep on coming. It works if you work it." So after a month of talking about what role trauma informed plays, Leanne had the best answer, and she said, "When you go to Washington, you tell him, now I know how I got here, and now you know how I got here." And that's exactly right. And that's the way I think about it. And patients don't know how they got into substance use disorder or trauma or a label like borderline personality or depression, or they don't really have oftentimes much insight into how that happened to them. And when you can tell people it's not what's wrong with you, but it's what happened to you that's shaping your behavior, and we can dig in, and here's how we can do it. We can create a safe place for you. We can create this place when you come to group, it should feel like, Dr. Sumquack is really looking after you, and it's you're not going to be re-traumatized, and we're not going to insult you or criticize your behaviors, or certainly people have behaviors during substance use disorders that they see as pretty nefarious stuff, right? And they self-critical, and certainly society marginalizes them. And lots of the folks come to us right out of orange jumpsuits or psychiatric facilities where they've been marginalized over and re-traumatized over and over and over again. So when you create that sense of physical and psychological safety, it's something that first people don't even recognize, and it needs to be continuously reinforced as the relationship develops. And again, it keeps on working as long as you work it. As the longer you stay in treatment and reinforce that secure empathic relationship with the patient, the better they get. And actually, there's another part of this, and I'll say for all of you all, without this can feel like a very bottomless pit, right? No hope. But there's a thing that we say in 12 steps: helping helps the helper. So as I was feeling this connection and knowing, right, my little epigenetics, there's methylation going on. I'm changing their DNA and they're changing my DNA as we're exchanging stuff in this relationship. I'm looking to create trustworthiness and transparency in a safe place. And I need peer support to do that. And we know that the patients feel a sense of safety and trustworthiness and a larger sense of transparency when they have someone caring for them that gets them, that understands them, and like a peer might. Now, there's also pitfalls with peer support, and the possibility that you could begin to look at every case like your own. And but peer support turns out to be pretty darn important. By the way, I stole this slide from SAMHSA, so if you disagree with it, blame them. But I think it's right on. It's about collaboration and mutuality. I don't say, okay, take this Prozac. I say, okay, here's some choices we have, and let's see what was going to work for you. This one has these side effects, and your insurance pays for, and that one is very expensive and has these side effects, and what do you think is going to fit for you? I know you go to work at 4 in the morning. Will you be able to take this before you leave, or when you get to the job, or again, some way help the patient understand that they're creating the treatment plan for themselves, and you're just there to record, maybe suggest, maybe amplify some details. Empowerment and voice and choice. That's the natural outgrowth of a mutuality. Well, you all know this. There's really only sort of three empirically proven approaches to the therapy of folks with substance use disorder. And the first one, which I really like, is motivational interviewing. The other one, and motivational interviewing to me, I guess I like it because of my athletic and my military background. It's a lot like coaching, right? It's like, okay, here's where you are and here's where you want to be, and how can we get you there? What can we change that will help you to meet this, get to this place that you want to be? Um, and by the way, that's also included in the ASAM 6 dimensions. In our company, I've insisted that we use the ASAM 6 dimensions from the fourth edition patient placement criteria to evaluate our patients. It gives us a sort of a 360 view of the patients. And one of those really important things is that you're making this collaborative, that if you're enhancing people's motivation, that you're helping to identify barriers to their care, and that they feel like, again, they're safe in your care. And they don't recognize this many times. So the more you reinforce that, the more they're able to sort of let that hypervigilance, let that guard down, let that adrenal outflow reduce a little bit. And then people have cultural, historical, gender issues. I guarantee you there's going to be trouble in Memphis today. The police were acquitted yesterday of the killing of Tyree Nichols. There are cultural, historical, and gender issues involved in all that. By the way, I just came from ASAM. I had to tell you that your likelihood of improving with the substance use disorder is definitely related to, your zip code, your gender, your ethnicity. Next slide, please. Yeah, you all know about these things. Buprenorphine, Vivitrol, Sublocade is an injectable form. There's also now Brixadi, methadone. Methadone sort of gets a bad rap from everybody, and methadone has its own unique pharmacologic properties that make it a little harder to prescribe safely than buprenorphine. Buprenorphine has, I first used buprenorphine as a resident in OBGYN, where we used the Buprenex, the injectable form, to give to moms while they were in labor. And the previously we used morphine and Demerol, and those drugs are straight what we call agonists. So all of their activity is morphine like, and so those babies came out sleepy and dopey and a little bit like a wet dish rag and not much respiratory effort. And but when we began using buprenorphine for labor pain, which was quite effective for the pain, those babies came out pink and lusty and vigorous and ready to face the world. We could use buprenorphine just like we use naloxone. We don't, but we could use it to if someone had an overdose, you could give them buprenorphine and it would antagonize an agonist. So, buprenorphine itself is a mixed agonist antagonist. Naloxone is added to, the most widely sold brand is Suboxone, of course. That naloxone is added there for only one reason. It's added there just so someone would be discouraged from injecting it. Now, I'm gonna tell you, in Memphis, every patient said at the end of the first week when I'd see him back, doc, I had to try it. I injected my Suboxone, and it was a bad idea. And why was that a bad idea? Because man, immediately they were in precipitated withdrawal. And then the second week, people would come back and say, I bought some heroin and I used it on top of my Suboxone, and that was a bad idea. And I say, why was that? And they said, because I wasted my money. Right? Those opiates receptors were already bound with buprenorphine. The heroin wasn't able to, lock into that receptor. Buprenorphine has a 30-hour half-life. That means, if you take it at 8 o'clock today, tomorrow at 2 in the afternoon, you still have half that drug in your system. Heroin has a 2-minute half-life. They wasted their money. Vivitrol, you know about that. There's also oral naltrexone. There's a brand name of naltrexone that's called Revia. Again, I mentioned Brixadi and Sublocade. I've had a good experience with Sublocade and Brixadi. Patients seem to like it. I think it relieves many of my fears about giving buprenorphine. It can't be diverted, right? You don't have to worry about compliance. I found it to be very useful. Adjunctive things, clonidine, spelled wrong. Absolutely, it's a central alpha agonist, and it does relieve some of those symptoms like the goosebumps and the sweats and the anxiety and all that. So, there's a window of time between your last fentanyl use and the first that we can give you the buprenorphine. And that usually is about 48 hours, sometimes as much as 72 hours. And even though the fentanyl effect, the analgesic effect and the high that's experienced has worn off, that fentanyl is still stored in the red cells. And so if you give somebody that buprenorphine too quickly, too soon, since between their last use, you can precipitate withdrawal, and that's pretty miserable. As a drug wears off and withdrawal comes on gradually, that's pretty miserable. But when it happens, like all of a sudden, those patients immediately hate you. They don't believe in buprenorphine anymore, and it's pretty tough to talk them into taking it again. By the way, buprenorphine is extremely useful. It gets a bad rap all the time too, but you're doubly likely to survive opiate use disorder if you're using MAT like buprenorphine. And people who get discharged to 12 steps groups, they have double likelihood, and no buprenorphine. They have double the likelihood of a fatal overdose. Yeah, there we go. There's some other things we can do to treat trauma. Use both sides of your body. You all know about EMDR. Not yet, not yet. Go back. Not yet. Dance, weight training, team sports, martial arts. Those aren't difficult. You can read about yoga and why it's useful. It's useful because of the bilaterality, just like EMDR, right? You want to wake your brain up, pinch your right cheek, pinch your left cheek, tap your right thigh, tap your left thigh. Your brain's more awake than it was 30 seconds ago. Over here it says psychedelics. Limited real evidence of benefits of psychedelics. I would say ketamine, I don't think belongs in that category. Ketamine, of course, is an anesthetic. I've used it in 1 milligram per kilo doses for 100 years in the emergency room. In psychiatry, it's used to treat refractory depression and PTSD symptoms in a dose of about 0.5 milligram per kilo. It's quite safe, and usually I'm pretty amazed at the effects patients get. It also seems to be a little vaccine against suicide. It lasts about a month. Yeah, next please. Yep, that's it. ¿Tiene preguntas? Anybody have any questions? I use up all the time.
I love it. Um, any questions? I know we are right at 9. I don't know if you have a minute or two to stay on if there are questions, Dr. Sumrok.
I can stay on as long as you want to. My daughter's graduating from high school, and after this, I am on vacation for a week.
Oh my goodness, congratulations. Wow. And I just have to say how amazing when you said 15 children. Extremely impressive. So makes me think about I have two. I need to think about, am I making them feel special and how can I do that today? But in addition to that, just want to ask, does anyone have questions they would like to ask Dr. Sumrok from the presentation?
No questions. I'm going to tell you that sometimes this message of trauma
I've got a
is not a
question.
popular. Yeah,
Oh,
go ahead.
Um, I'm Jeff Mitchell, LPC.
Yeah.
I got a lot of adult clients that are on Suboxone, and they say that when they first started, they said it'd be about 6 months, and sometimes they're into this for 3 or 4 or 5 years. I mean, what are your thoughts on this?
Uh, so it's a drug that keeps people alive. It's a drug that looks like it's more effective at treating depression than the current SSRI choices that are available to us. There are some side effects to taking a drug like buprenorphine chronically, like any opioid. It suppresses your adrenocortical endocrine function. So patients often need things like testosterone replacement for that, and you got to keep an eye on their thyroid and all that. But it's in general a very safe drug. It's very well tolerated. People aren't craving or having withdrawal when they take it. Because they're not craving it means that they can actually participate in therapy because they're not thinking about using all the time, and they're actually able to attend, be attentive. So it's a chronic illness. I think if, like any chronic illness, you have a medication that's the benefits seem to be outweighing the risks, then I think it doesn't make much sense to take it away. And I don't care if it's saving somebody's life, and we
Okay,
can
thank you.
say that there's a benefit. I don't care if they take it for forever and ever. Amen. I think that the other
Yeah.
side of that coin is the assumption that we're all better off with no medication, right? The way we came into this life, the way God sent us with no medicine, that isn't always true, right? If you have diabetes, it's a chronic illness. We want you to keep taking that insulin. It's going to keep you alive, and I think of this very much like diabetes. So I don't have an objection to that. I think that the other uh, attitude toward MAT, which is that you should be off it as soon as possible, reinforces stigma. So,
Okay.
mhm.
and then people start using words like clean. You know, I got a call yesterday. The patient's not clean. He's taking methadone. Well, that reflects your stigma more than the patient's clinical condition. So,
One of my takeaways is, I'll just be honest. So I'm a LCSW, and when I was in school, we didn't have a lot of training on ACEs or trauma and how that affects,
yeah.
mental health, substance misuse. And so for me, my takeaway is making sure that I'm doing my due diligence to find out as much information as I can on how this is all interconnected and what the relationship is, and making sure I'm always keeping that peace in mind when
Yes.
working with this patient.
Yes. So several of my therapist friends say, it's dangerous to mine for trauma. And I get that. I understand that. That it also, sometimes I'll put in a consultation. Please consider patient for EMDR, and I'll get an answer back too early, too soon, not ready. And so I'm not exactly sure how long we have to withhold the truth from a patient, right? And when it's okay for us to say, okay, now you're ready to actually have the true story. Uh, again, some people aren't ready because they're psychotic when I see them, and they can't incorporate any new information. But the idea that you have to protect people, they used to say, "Don't tell grandma she has cancer." I'm going to tell you, I found that plenty of examples where it's been proven to me that it's best to be completely frank with people and upfront, and you can't jump over the hurdle till you run right up to it. So if you're trying to help people get better, it doesn't do much good to delay the truth for them. I'll tell you too, it's empowering when people realize, it's not something wrong with me. It's something that happened to me. I'm okay. I'm not a moral failure. I don't have this characterologic flaw that has sentenced me to this life of marginalization. Something really bad happened to me, and it has a predictable effect, right? Heart disease, cancer, COPD, accidental death, depression and suicide, all those things that we just talked about. And now we can understand how we got here. Now you know how I got here. Now, I know how I got here. That's super important for people. And then the shame and guilt lifts, right? And shame and guilt doesn't get you out of addiction, it keeps you in it. It's the same with trauma or with I'm sorry, eating disorders. Eating disorders, same. It's the same etiology, same adrenergia, same striving for predictability. And people that have had trauma, they don't like surprises. They like each day to be predictable. And actually, one of the neat things about taking care of people with compulsive use disorders is, once people get a handle on it, they're really good employees. They show up on time, they stay, they get work done while they're there. They're very compulsive about things. And if someone has they're addicted to fentanyl, they know exactly how many tablets they have to last until Thursday when they see the dope guy. And look, if a little corner breaks off one of those pills there, oh, somebody's been in my my supply. They're very organized. So I think it's a mis description to talk about these folks as having unorganized lives, and actually they're very compulsive.
Any other thoughts or questions, comments?
Hey, good morning, everybody. I'm Elizabeth Greenbaum. I'm a peer support specialist at Arkansas Blue Cross Blue Shield. And I guess one of my comments and kind of leading into a question is like my ACEs score is relatively low, even though I am an addict, and I feel like most of my trauma was brought on by my addiction and the things that I did and the stuff that I went through. Um, but I love to talk about the ACEs and learn more about it when I'm speaking with individuals and letting them know, this is such great information. And again, it's what the doctor said, it's not what's wrong with you, but what happened to you, and being able to see a light come on above people's heads and being able to have that conversation, I think is amazing. And this is really very informative. Thank you for having this today.
Well, thank you for your observations, and I think you're right on and completely consistent the way I think about this. I have an NBA player that's a patient, and I always ask people the same question. I asked him, I said, do you remember what it was like the first time you used heroin? And he gave the same answer that, so far I've had about 50,000 people that I've treated individually. And he gave the same answer that 49,999 other folks gave. He said, my fear went away, my pain went away. It felt warm and fuzzy. I felt like I was in a safe place. So, that's a strong signal to your brain to do it again. Who else? Anything else? Please, don't be shy.
It was totally amazing. So much wonderful information. We appreciate you being here and, sharing your experience and sharing all of this information. We're so grateful that you're here in Arkansas working, and we look forward to connecting with you, and have a wonderful vacation. And
Thanks so
congratulations
much.
to your daughter.
Yeah, and if you'll stay in touch with Kyle, it's perfectly okay for him to share my contact information. If any of y'all want to call or email me at any time, I've been on call since 1972, so I always answer the phone. So
Okay, wonderful, wonderful. I'm sure people will be taking you up on that.
I'll put my phone in the chat.
Fantastic. We truly appreciate you, and thank you all for being on with us, and we'll see you back in June. Take care.